all of us should be able to make informed choices about our sexuality and reproductive well-being. And this includes the rights to access to education, information, services, and quality health care. So SRHR includes the right to choose whether and when to have children, the right to exercise one's sexuality free of violence and coercion, the right to seek pleasure with respect to other people's rights. And the issue of pleasure is something that many people frown on in this discussion. But as Jacques may point out, that the research that the Department of Social Development did found that young people who engage in sex with consent and for pleasure are less likely to fall pregnant and are less likely to be subjected to forms of sexual violence. And these are the kind of issues that we must be speaking about as well. And it's often taboo issues. So given South Africa's youthful population and the youth dividend that Dante's spoken about, investing in SRHR for young people is crucial. I think this includes implementing a comprehensive sexuality education program. And again, just to point out that evidence that has emerged over the years about CSE is that it does reduce risky sexual behavior. It reduces unwanted pregnancies and also reduces levels of sexual violence. As South Africa and any strategy within this pandemic, we need to commit to develop youth-friendly services where young people can access contraception and if the need arises, access to safe termination of pregnancies without fear of stigmatization. And this is particularly important within the pandemic where there's a prioritization and a hierarchy that's emerging, and rightfully so in many cases, about who gets access to health care services and who does not, given the kind of the spikes in the pandemic and the stresses on the health system. So I think that all the other speakers will probably unpack this a bit more, including, for example, what does CSE means and how to debunk some of the myths that have emerged from that. So for South Africa going into the Generation Equality Forum, what we should be doing is championing and leading debates and discussion to ensure that girls, adolescents, and women in all the diversity are empowered and supported to exercise their sexual and reproductive health and rights and make autonomous decisions about their bodies, even within this pandemic. Zandi, I think that these are the kind of issues that we would be expecting South Africa to be championing in Paris later this month. Thank you.
Thank you, Mr. Dango, for those very wise, welcoming remarks. Colleagues, as Mr. Dango was highlighting, that today the focus will be on sexual reproductive health and rights. In South Africa, access to healthcare, including reproductive health, is a constitutionally recognized right under Section 27 of the South African Constitution. The South African Constitutional Court has linked the realization of socioeconomic rights to the right to life. It enjoins the state to take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights. As a signatory to the Covenant on Economic, Social, and Cultural Rights, the South African government has an obligation to promote and protect, as well as take reasonable measures to realize this right for all. In addition to these legislative frameworks, the human rights-based South African foreign policy places an obligation on DIRCO to promote this right in its international engagement. COVID-19 has exacerbated the challenges regarding the progressive realization of comprehensive sexual reproductive health rights for adolescents and youth due to the incalculable, devastating impact on health systems, economies, and access to essential health services. Women and girls have been disproportionately affected, with sexual reproductive health services being curtailed and gender-based violence on the rise at unacceptable high levels. The crisis has also exacerbated a pre-existing lack of access to health, well-being, and reproductive services, as health systems have redirected resources to deal with the outbreak of COVID-19, resulting in sexual and reproductive health services being deemed as not essential. The pandemic came weeks after the Nairobi conference, which took place in 2019, which had not only appraised the progress on the ICPD implementation, but also had renewed the international community's commitment to understand the exacerbated impact of COVID-19 on the socioeconomic determinants of adolescent health and well-being in the region in relation to access to sexual and reproductive health services for youth and adolescents. Please welcome Ms. Beatrice Mutali, who is UNFPA's country representative in South Africa. Ms. Mutali, over to you.
Thank you, Zandi, and thank you, Zain, for the warm welcome. And a very good morning to all the participants. I trust that you can hear me.
Yes, we can.
Great, thank you. So I'd like to start, speaking on behalf of UNFPA, I'd like to first start by really thanking DIRCO for the invitation. From UNFPA, we strongly believe and support meaningful youth engagement. And in this regard, we commend the organizers for bringing youth perspectives and voices into this very important discussion. I think Zandi and Zain gave really good introduction and were able to really contextualize the discussions that we are going into during this session. And just to move on, the past year, as we all know, has brought us a complex context with the outbreak of COVID-19, the COVID-19 pandemic. Across Eastern and Southern Africa, we have seen other challenges as well, challenges resulting from climate change, conflict and fragility, all of which have added into the existing structural inequalities. The negative macroeconomic impact of COVID-19 on GDP for 2020 in this region is estimated % in Eastern Africa and negative 3.4% in southern part of Africa, with even worse impact on smaller economies. This is actually based on the World Bank projections. Disruptions, as stated earlier by Zandi and Zain, disruptions have impacted all sectors, the labor markets and livelihoods, especially in the informal sector, resulting in a projected 0.7 increase in poverty levels. For those who are economically or socially vulnerable before COVID-19, their vulnerabilities have been worsened by the pandemic, as their socioeconomic situations, their safety, their health, have all been negatively affected. This is especially so for the adolescent girl and for young women. And I'd like to explore some of the implications. I will take the approach of picturing the situation of an adolescent girl from a poor community and look at how her life has been impacted by the pandemic. And I'd like to explore this through three main dimensions of impact and speak to some of the emerging data from Southern and Eastern Africa as I do this. The first dimension I'd like to look at is how lockdowns have affected access to school health services and increased the risk of suffering with regard to gender-based violence. Lockdown, as we all know, impacted the adolescent girl, as she or the adolescent girls could no longer go to school, had less access to transportation, especially in remote areas. It became more difficult to go to health clinic, for example, even to get ART for those in need, or to get contraception or other sexual and reproductive health services. The lack of mobility also kept the adolescent girl at home all the time, potentially increasing her risk of abuse, sexual and gender-based violence by family members or close persons. Adding to that, evidence from the region indicates that lockdowns and fear of contracting COVID in a health facility have shifted health-seeking behavior, leading to major reductions in the use of health services, thereby compromising continuity of care for people living with HIV, tuberculosis, and other chronic diseases. In South Africa, a telephone-based survey that was supported by both UN Women and UNFPA on health-seeking services found that women who were of a higher age were more able to access services. Some of the data shows that women aged 55 and over, at least 46% reported being able to access services. Those aged 34 to 54, 38% reported being able to access services. And then those aged, only 35% reported being able to access services. So this data in itself signals that young women may have faced challenges in either seeking services or in accessing health services. The same study also found that most men and women, 81% and 90% respectively, did not seek sexual and reproductive health services during the lockdown. Further, the disruptions in the provision of critical sexual reproductive health, maternal, child health, and adolescents health services were also documented in several countries of the region, especially during the first peak of the pandemic. For of ranging from -10% in Tanzania to -87% in Angola. Antenatal care visits declined in 5 of 13 countries that had available data, and there is evidence of increased maternal deaths in a number of countries. The same pattern has been identified with regards to gender-based violence services. While global evidence points out to increased rates of domestic abuse in the context of the COVID-19 lockdowns, the search for services has been reduced, especially for the younger cohorts. In South Africa, the telephone-based survey that I alluded to earlier found that a small percentage of women, 5% surveyed, reported seeking GBV services for themselves since the start of the pandemic. Within this group, again, those aged 55 and older were more likely, were better off in that 43% reported seeking services. Those aged 35 to 54, 9% reported being able to seek services. And those aged 18 to 34, that dropped to 5%. And again, you see the impact on young people. So briefly, that was the first dimension I wanted to talk about. The second dimension I'd like to talk to is how school closures affected educational prospects, comprehensive sexuality education, the burden of household responsibilities, and increased early marriage and pregnancy. As noted in previous discussions, a major implication of the pandemic for the adolescent girl has been on the closure of schools. For many adolescent girls, this has meant either being suddenly placed in remote learning or no learning at all, as challenges with access to internet, electricity, and IT equipment hampered remote attendance to school for many. Comprehensive sexuality education was also challenging in remote settings. Finally, for the adolescent girl, being at home meant that most of the time this resulted in an increase in the burden of household responsibilities or more pressure from family for early marriage. In Malawi, an 11% increase of teenage pregnancies between January and August 2020. That is compared to the same period in 2019. In South Africa, the lockdown regulations affected nearly 13.1 million learners. While distant learning mechanisms were attempted, they were not always able to reach vulnerable children and young people. The provision of comprehensive sexuality education in and out of schools was impacted and required innovative program interventions to ensure continued flow of information to adolescents and youth via alternative media, social media, WhatsApp, and specialized apps. But again, that was for those who are able to have access to those platforms. That was my second dimension. I'd like to move on to the third dimension, where I'd like to explore how loss of livelihoods and the impact on nutrition and access to basic supplies. Loss of jobs and disruptions in the informal economy meant less money in the household. For an adolescent girl, this meant potentially less access to nutritious food with consequent impact on health outcomes. It also reduced the possibility of accessing basic items such as sanitary pads. In the East and Southern Africa region, young women 15 to 24 years were up to 17% less likely to be in education, employment, or training than young men, even before the pandemic. And the overall adverse impact of COVID-19 on income loss will likely be much higher for this particular group. Income loss means for adolescents access to nutritious food at home and elsewhere. In South Africa, an estimated 9 million children normally benefit from school feeding, but were more vulnerable during the protracted school closure as school feeding programs were disrupted. Hopefully, these three broad dimensions provide some insights into the impact of COVID-19 on adolescents and youth in practically all aspects of their lives. As you can see from this snapshot, the reality is that the pandemic has begun to roll back gains in sustainable development, particularly progress in gender equality and the rights of women and girls. It has, again, consequently begun to roll back some of the gains that were that we saw during the Nairobi summit that Zandi alluded to in 2019. So the question is, how can we urgently counter this process and build sustainable gains? From UNFPA's perspective, I would like to leave you with three key actions which we deem as critical. We really emphasize the need to advocate for continuity of sexual and reproductive health services as an integral part of COVID-19 response and recovery plans. And more importantly, make sure that adolescents and youth-friendly services are available in different modalities, in person, but also via telehealth and other virtual modalities. Secondly, I would like to recommend the strengthening of referrals within the network of GBV services, as well as quality of assistance to survivors with dignity, confidentiality, and respect. And then thirdly, would like to recommend promotion of economic relief and social protection mechanisms that can enhance security for households, as well as digital inclusion. I thank you.
Dear colleagues, I don't know if it's just my side, but it looks like we have lost Ms. Mutali.
Yes, we have.
Well, I would like to thank her for her presentation on some of the very scary and worrisome trends that we are seeing in the region. And I am having a bit of connectivity issues, so you're gonna see my camera on and off because of such reasons. But nonetheless, Ms. Mutali has just highlighted some of the very critical issues here, including some the disruptions that have been experienced due to COVID-19, but also just how the digital divide is also not helping with some of the innovative ways of trying to increase access for adolescent girls and young women. So these are some of the issues that I am hoping that in our interactive discussion can be further unpacked by our very able panel. So with that said, we will move on to the next topic.
When one has these discussions, is that civil society should be involved in the design and implementation of population policies and programs. So I suppose after the Constitution, that's the next level of major strategies that relate to gender, women, youth, and children are relevant in this discussion. And maybe just to flag three of them, the promotion of responsible and healthy reproductive and sexual behavior to reduce the incidence of high-risk teenage pregnancies, unsafe abortion and sexually transmitted infections, including HIV/AIDS, through the provision of life skills, sexuality and gender sensitivity education, user-friendly health services, and opportunities for engaging in social and community life. That strategy works hand in hand with a strategy to advocate and facilitate measures in order to enable women and girls to achieve their full potential through the elimination of all forms of discrimination, the more effective implementation of laws that protects women's rights and privileges, and then a third highlight, and the one that we often forget about, is the promotion of equal participation of men and women in all areas of family and household responsibilities, including responsible parenthood, reproductive health, child rearing, and household work. So I think sort of this sequence of principles, concerns, and strategies that hang on the Constitution really, sort of lay out the country's approach to sexual and reproductive health and rights, and obviously, as Zane has indicated, emphasizes young people and particularly adolescents therein. Now, in the period 1994 to 2015, is the ICPD Program of Action, which was adopted in 1994, and our democratically elected government participated. And then the South African delegation at that conference was very active, as well as in the subsequent ICPD +5 conference, in which substantial amendments were finalized to the ICPD. That was obviously carried through into the Addis Ababa Declaration that Zain has referred to, as well as the Nairobi commitments that Zandi referred to just now. So in the international space, the country has positioned itself significantly as an advocate for sexual and reproductive health and rights in a very inclusive and broad way. We've also, particularly in the 90s, seen a very rapid development of various legislation and policies that relate to SRHR, and I think those who've been around for long will remember that the Department of Health initiated the adolescent-friendly youth service approach in health. The Department of what is now the Department of Basic Education, incorporated sexuality education into the life orientation curriculum. And of course, we've seen legislative changes, for example, the introduction of the Choice on Termination of Pregnancy Act as well. So there has been a sort of a domestic expression of the international commitments in a way that is even more progressive than the international commitments themselves. What I think is also important to emphasize around the policy developments of those 20 years is that a lot of it took place within particular sectors. So we never got around to formulating a umbrella sexual and reproductive health and rights policy in the country that's inclusive of all sectors. But what we've rather seen is that there's been policy development consistent with the principles of the Constitution and the population policy within individual sectors and with varying degrees of collaboration between departments and other stakeholders. National treaties, conventions, and resolutions of military supported, as well as the then expression within the policies and plans and guidelines of the different, particularly in the education sphere, strengthening of services, particularly in the health sphere, and then the dimension of community supportive networks for adolescents, as well as evidence and policy-based revisions. So what I'll do to conclude, and then I'll add the rest of what I had to say a bit later, is that
in his report addressing inequalities and getting back on track to end AIDS by 2030, the United Nations Secretary General Antonio Guterres underscores that addressing social and structural factors that perpetuate inequalities is key. He highlights, for example, how gender linked by harmful gender norms restricts women's use of HIV and sexual reproductive health services by perpetuating gender-based violence, power, including the ability of women and girls to refuse unwanted sex, negotiate safer sex, and mitigate HIV risk. Generation Equality Forum, through its Action Coalition on Bodily Autonomy and Sexual Reproductive Health and Rights, accentuates the importance of increased quality of and access to contraceptive services for 50 million.
Yes, we can. Thanks.
Okay. So thank you so much for the opportunity to present to you today. So my presentation will be covering the UNHLM Declaration and the UN Global Strategy on Ending AIDS and its implications on the implementation of the National Strategic Plan for HIV, TB and STIs in the era of COVID-19, and also the effects on key populations, particularly the youth in this context. And I think before we start, it is important for us to really view HIV and AIDS epidemic as not only as a country issue, but as a regional and global crisis that requires extensive amounts of partnership, collaboration, as well as lessons sharing for us to realize our ambitious 2030 goals. To give you an overview of my presentation, I'll try to be as brief as possible. To start really understanding the Sustainable Development Goals and the implications of those goals, and sort of understand what we are working towards from a global context, and also just to highlight some of the key priorities that came out of the high-level meeting on AIDS Political Declaration, as well as the Global AIDS Strategy for 2021 to 2026, and then the health and economic status of adolescents and young people in South Africa, as well as the South African National Strategic Plan for HIV, TB, and STIs, the impact of COVID-19 on HIV response among adolescents and young people, and what are the key areas of strengthening that we have to sort of focus on. So just to give a bit of an outline, the Sustainable Development Goals are global commitments that aim to elevate the development of people and the planet. Goals would be ending poverty and hunger, ending inequality, building peaceful, just, and inclusive societies, protecting human rights, promoting gender equality and empowerment of women and girls through resources. So one of the key things that we need to really look at as it relates to these particular goals is that they are very, very interlinked and very interrelated. And sometimes responding to one of the goals also in some way response to all the other goals. So the high-level meeting commitments and the Global AIDS Strategy are cohesive efforts towards the achievement of Goal 3 of the SDGs, particularly as it relates to bodily autonomy and SRHR. So Goal 3 relates to good, like I've already indicated. If we look at Goal 4, Goal 5, Goal 8, and Goal 10, somehow our response in the SRHR space really is also responding to those goals. And then just to give us a bit of an outline of some of the key, notes that were made at the HLM meeting, is that just to highlight Ms. Winnie Baima's opening remarks, when she said that AIDS is not over, and it is one of the deadliest pandemics of modern times. And since the start of the pandemic, almost 77.5 million people have been infected with HIV, and we have lost nearly 35 million people to AIDS. And that AIDS deaths every minute is an emergency. And then whether we want to be remembered as promise breakers or promise as people who ended AIDS, or only as people who could have ended AIDS, is really up to us, and I think up to our efforts. Just to also give a bit of some of the key outcomes or some of the key things that the HLM aimed to do was to review the progress, to provide recommendations, to guide and monitor HIV response beyond 2021, and also the promotion of new concrete commitments of engagement and commitments from leaders and key partners in ensuring that the implementation of the HIV response. So some of the key priorities that came out of the HLM as it relates to SRHR and adolescents and young people focused are gender equality and empowerment of women and girls, engaging men and boys as agents of change in intensified efforts to transform negative social norms and gender stereotypes, as well as to commit to put gender equality and human rights of all women and girls in diverse situations and conditions at the forefront of efforts to mitigate the risk and impact of HIV, just to mention a few. And some of the key ones was to also reduce the new HIV infections among adolescent girls and young women to below 50,000 by 2025, and to ensure that by 2025, 95% of women and girls of reproductive age have their HIV and sexual and reproductive health care services needs met, including antenatal care and maternal care, information and counseling. Just to give a bit of a brief as well on the global AIDS strategy, the approach to use those the gaps that are preventing progress towards ending AIDS. It aims to reduce the inequalities that drive the AIDS epidemic and prioritize people who are not yet accessing life-saving HIV services. And that is from Ms. Winnie Baima, who's the executive director of UNAIDS. So just to also outline some of the strategic priorities that the global AIDS strategy aims to achieve is to maximize equitable and equal access to HIV services and solutions, and break down barriers of achieving HIV outcomes, and then fully resource and sustain efficient HIV responses to integrate them into systems of health, social protection, humanitarian settings, and pandemic responses. Just to come back to the South African context, we have the National Strategic Plan, which has 8 goals, and these goals really focus on accelerating there's a reduction in illness and death, and also to focus on key and vulnerable populations, ensuring that we also address social and structural drivers that perpetuate HIV, and also to promote leadership, mobilize resources, and the use of information. So just also to give a bit of a statistical context when it relates to young people, is that youth aged 15 to 24 in 2016 had new infections of 107,000, and then that reduced to 21% to about 85,000 new infections per year. Oh, and then also just to look at the difference between men and young men as well as young women, is that young men have a reduction rate of 26%, while young women only sit at 18%, which means that we need to really increase our efforts. And as much as there is good news that the number of new infections is being reduced, however, it's not happening at the rate that we needed to happen for us to be able to meet our targets. Just also to outline that South Africa also had a national campaign, which is called She Conquers, which also aimed at elevating the needs of young women, especially decrease new HIV infections in young women, and also decrease teenage pregnancies, keep girls in school till matric, decrease sexual and gender-based violence, and also increase economic opportunities. So this particular campaign was more of a coordination campaign, which was joining the dots from civil society, local government, private sector, implementing partners, NGOs, government, and you count all the key stakeholders that are important to this particular movement. So also for us to recognize that She Conquers has core package of interventions that are biomedical interventions that may focus on HSC services, as well as treatment adherence programs, as well as behavioral and structural change interventions that focus on risk reduction programs, parenting programs from a community perspective. And then these particular programs are segmented according to the young people's age groups and their needs, as well as what is more urgent to young people. Just to also summarize that these are some of the implementing partners that are currently in South Africa, from the Department of Health, Basic Education, Social Development, the Global Fund, the MRC, Johnson & Johnson, just to name a few. And also just to say that over the past 3 years, approximately 4.8 billion has been committed through donors towards the implementation of AGYW HIV prevention programs, and then that the most common settings are schools, institutions of higher learning, PHC facilities, and some programs have a community outreach component through its clear 20 to 24-year-old. Although it's clear that 20 to 24-year-olds remain the hardest to reach. Just also to give, I think at the end of our discussion, we will sort of engage with some of the statistics and what are some of the key things that we really need to focus on to just strengthen and ensure that the gender disparity, especially as it relates to infections, is not as wide. So I will not spend time on these given the time restrictions. So just also to highlight the infection pathway, that when teen girls reach mid-20s, they do continue the cycle because they then have they have older male sexual partners, and then when they reach the age of over 24, that's when they usually then have groups, and then the infections then rise at that age because they at the point where they were having sexual relations with men who are older, they may have gotten infected or have had higher risk of infection. Also to say that the total number of youth 15 to 24 is 9.57 million, as indicated by Stats SA, and also that 3.6 million they are in grade 9 and grade 12, and also 1.7 million in universities and TVET colleges. Also to say that 3.2 million are not employed in education or training. And also that we need to note that there is a transition in our thinking from focusing on adolescent girls and young women only, as indicated by the She Conquers assessment. Also, if we then draw in on the NEET group, we are then realizing that youth, 36% of youth are categorized in the population of South Africa. And also young people aged between 15 to 34 make up to 70% of the total unemployment over the last decade. And it is also important to note that 75% have never worked before and have been seeking employment for over a year. Just to bring it back to the NSP and the focus on adolescents and young people, in 2018, the HSRC surveys found that over a third of all new HIV infections in South Africa comes from the age band of 15 to 24-year-old. And the National Strategic Plan for HIV, TB, and STIs categorizes adolescents and young people as one of the key and vulnerable populations. The need for comprehensive SRA is addressed by Goal 3 of the NSP, which focuses on providing comprehensive services for key and vulnerable populations. And there's a realization that there needs to be strengthened efforts for adolescents living with HIV or young people living with HIV, youth with disabilities, adolescent boys and young men, and young people who belong in the LGBTQIA+ community. And also to note that Goal 4 of the NSP focuses on addressing the social and structural drivers of HIV, which exacerbate the risk of adolescents and young people. And these can be realized through expansion of SBCC campaigns, reduction of poverty and unemployment, expanding comprehensive package of interventions through a revitalized youth health prevention campaign, which is a successor of She Conquers, and to optimize GBVF prevention, to establish those interlinkages between the HIV NSP as well as the GBVF NSP, to reduce harmful use of alcohol and drug abuse among adolescents and young people, and also increase TB and STI interventions among those young people. Just to give you an overview, these are the key tools that exist to prevent, such as oral PrEP, as well as soon injectable, as well as condoms, male and female condoms, STS services, as well as treatment as prevention. Just to also highlight what are the key challenges that came out of the COVID pandemic. The challenges were that lockdown restrictions reduced adolescents and young people's access to comprehensive sexual and reproductive health services and resulted in defaults in PrEP, in ART, in contraceptives, and limited access to condoms, HTC, as well as we saw also an increase in the number of lost to follow-up cases. And we also saw a decrease in the number of 90-90-90 gains. And also we saw an increase in mental health issues among adolescent and young people. Alcohol binging and drug abuse became a very, very grave problem, as well as an increase in the unemployment rate. Some of the key recommendations that are coming up is that we need to start upscaling SRH services for adolescents and young people. We need to develop a catch-up plan to counter the drawbacks of COVID-19. We also need to develop innovative strategies of continuing engagement with adolescents and young people amid a pandemic. And also we need to strengthen partnerships with DBE to use schools as entry points to reach youth in school, as well as strengthen support for CBOs, particularly for hard to reach youth that are in rural settings. Some of the key areas of strengthening focus on as we move forward is to strengthen the contribution to the SDGs, the HLM Declaration, and the UN Global Strategy Goals, as well as the NDP, PIPs, and the MDIPs. As well as one of the key things that are happening is that there has been an NSP deferment so that we are able to develop a catch-up plan, and then we are able to catch up on some of the losses that we had to endure due to COVID. And then as well as finalization of the new HIV prevention campaign that is inclusive of adolescent boys and other key populations that may have been left behind with the previous campaign, and to strengthen youth capacity building and leadership in the HIV response, as well as support HIV and GBVF interlinkages efforts, as well as to optimize key NSP activities at national, provincial, and local level. Thank you. We will take questions and further clarifications as we move towards our discussion. Back to you, Zandi.
Thank you very much, Koketo, for such an insightful presentation. The patterns are very clear here. While we made so many gains at the beginning of the 2000s with the reduction of mother-to-child transmission, from your statistics, we can see that we seem to have lost those young people because they are the age cohort you just mentioned that HIV statistics or infections are growing among. So I know that we have the She Conquers, we participate in the She Decides. What is it that we are not doing right? I remember how in the early 2000s, the government itself was very aggressive with rolling out CSE in schools. Is there some, did we lose focus for us to be in the situation that we are in and
sitting on these platforms? So we moved on to pushing the agenda of ensuring that young people are able to conduct youth-led, community-led monitoring at different levels, where we've been able to continue collecting evidence that has actually been speaking to young people, continue to engage, what kind of evidence they're actually giving out for us to be able to demonstrate what is actually happening, the needs of the communities that these policies that policymakers are actually putting in place, the real impact, the availability, the accessibility, the affordability, acceptability, as well as the quality and effectiveness of the services that are being provided to the young people. That was our initial focus, and I think we did win quite a bit there. However, in the long run, I think one thing that we've also come to realize is the power that the religious leaders have, or religion in general, actually has in terms of, in as far as programming is concerned, as well as our traditional leaders, how much power and influence they have. I'll give specific examples on, no matter how actually want to be, there are certain areas where even when policy speaks to promote easy access to contraceptives or family planning services for all ages, all adolescent girls and young women, there are barriers that have continued to exist. Some of them are based on religion. Specific examples could be on some of the projects that we're implementing, supported by, an example is SAT, okay, within one of the districts in Zambia. But there are certain areas where you have so much influence from the religious leaders and traditional leaders, where all these services, even when they are allowed by the policy, with themselves, they're operating within their own policy system, and those services are still denied. An example are contraceptives themselves, where in a place called Macha, it's a huge village. Within that particular village, and they have a very big mission hospital there, no single woman or girl unmarried is allowed to access contraceptives there from that particular facility. So for the first visit, they need to be accompanied by a man who should either be the husband or the father, or maybe the friend or something. Somebody needs to show up as a husband for them to be able to access services for the first time at that particular facility. So for us to go around that, we tried engagements with religious leaders who are part of that particular mission hospital, who are in charge of the mission hospital. We also tried to go through they were then told to do what we're proposing, because what we're proposing was for us to be able to provide mobile services, like mobile services there, because once a woman accesses the service for the first time, and you provide them with a card for family planning, then they can continue accessing these services going forward without any accompaniment. So to do that again, even when the hospital was willing, we still needed to go through the traditional leaders. So again, engaging the traditional leaders to make them understand the need for this particular service to be provided to the women, seeing how many adolescent girls and young women continue to fall pregnant, how many unsafe abortions were being conducted. Abortion isn't accepted, isn't actually allowed within the particular facility, but they are accepting post-abortal, they are actually giving or providing post-abortal care to so many women. So we did make our argument to look at the costs that they're actually incurring on both sides. So the best compromise was for us to be able to provide these mobile services. So long story short, it's actually a process where we've been able to learn how powerful the traditional leaders are, or the traditional system is, and how powerful the religious leaders are. But the power that the religious leaders have, even in our conversation, I think one thing we've tried to make very clear is that we from our end really sympathize with their position, because you realize the Bible will never change. It hasn't changed since it was put together, but times are changing. The needs of the adolescents and young people that they're providing leadership over are also changing. They're evolving over time, and they need to also be able to ensure that the other services or needs that these young people actually require as they move forward are also attended to. So it's a part where you actually come to realize that the church realizes the need, but sometimes they are stuck because they may not be able to move the agenda themselves, but they need somebody somewhere to be able to point out on this particular need and offer solutions on what needs to be done. The biggest lesson actually came through during the CSE conversation around the country when the church rose up to speak against CSE. So again, within that, as a platform, it was an issue of trying to actually identify the best route to take, realizing how powerful the church can actually be, especially within an election year, when you know that every political leader will definitely listen to the church because they don't want to lose the voters, they don't want to lose votes, so they'll definitely listen to the church. So we also positioned ourselves to be able to have a sit down with the church and dialogue to really identify where the challenges were, what they thought was making them uncomfortable within the CSC curricula. Was it the entire curricula? Was it certain parts of the curricula, which they obviously made very clear that wasn't the entire curricula, but to certain parts of the curricula that made them uncomfortable. And we did agree with them that we needed to sit down together with them and really discuss. For some parts of the curricula which they pointed out as making them uncomfortable, we realized again it was an issue of probably a certain level of lack of meaning of certain things and the way and what context they were actually being brought in. So we realized that with a proper sit down, they could definitely be able to understand and appreciate the reason why and the need those particular components were put in there. One thing for sure that we continue to propagate as a platform is that there's no single entity or single player that can claim to have the best interest of the young people alone and be able to deliver everything that the adolescents and young people need. We need support from each and every sector to actually play a role for adolescents and young people to be able to be well catered for and for them to achieve or enjoy sexual reproductive health services, as well as enjoy their rights every single day. Of course, we continue to learn of new challenges that are coming in now that COVID has happened. There are other challenges that are coming in, and we have to continue innovating to ensure that we still remain responsive to the needs of the young people, to ensure that the services being provided by the Ministry of Health and the different players are still responsive to the needs of the young people, and they are able to reach the young people where they are and within their times of need. So from the platform perspective, I think these are some that we've been able to evolve over time. And also realizing that some of these religious leaders and traditional leaders are also part of other platforms within the country, and they play driving the agenda, whether be it HIV or sexual reproductive health, or indeed CSE itself. A good example is our chair, the chairperson for the country coordinating mechanism of the Global Fund in the country, Bishop Paul Mususu, who is also one of the key leaders within the religious setting. Okay, one of the church mother bodies. I think he's also a chair there in that particular sector. So these are people that appreciate both worlds, even though, again, sometimes I think the part that wins is where they're probably, I don't know whether more convincing, there's more evidence, they're speaking to some of those moral values and the like. So, I mean, this has been the journey. And what we've done so far is to try and incorporate within our work to also try to document some of those gaps that exist within the religious setting, within the traditional setting. What are the gaps that continue to exist or hinder? What are the issues, the barriers that hinder access to services for young people? So I've incorporated some of those things in our tools, and this is data that we are now beginning to collect to also inform what we are supposed to be doing around that. Because of course, our data collection is also followed up by some form of action through interface meetings with the key leaders as well as the young people. We've done a lot with young people interacting with the healthcare providers, but now we are moving into a space where we want interface meetings between the young people, adolescents and young people, and the traditional leaders, as well as young people and the religious leaders, for them to actually interface and frankly speak to certain needs and how best these needs can actually be addressed. And we do believe that this will be something that will be very effective. We've gone further to include some of the religious leaders, some of the young people from the religious community, appointed by the key religious leaders to be part of some of our processes, like for instance, the National Youth Accountability Coalition, which now has young people appointed by the key religious leaders in the country to sit and be part of this particular coalition, who are reporting back to their leaders on what the young people want, what some of our advocacy agenda is speaking to. Yeah, so that is what we've gone ahead to do, to continue to address and respond to some of the key challenges young people are facing. We realize the ministry is listening, they've been paying particular attention, and they've been able to make adjustments based on recommendations that we're providing in terms of the interactions that we've had with them. But we also know that some of the barriers around that are driven by religion and some of the barriers driven by tradition will not go away based on just the Ministry of Health trying to be responsive, because religious leaders are also driving a huge part of the health sector. Traditional leaders also have huge influence over what kind of services the people can actually be able to access and continue to enjoy. Thank you.
I wish to thank Sibu for sharing the experiences from the Zambian Youth Platform. I do hope that these best practices can be shared at the regional level so we all can. We see that religious leaders as well as traditional leaders and governments and other civil society members, when it comes to the issue of SRHR as well as CSE, we don't always see eye to eye, but it is always for the benefit of our own community. So thank you very much for taking your time to join us today for this very incredible panel. Generation Equality Forum is grounded on intersectional youth leadership to ensure that the youth voices, perceptions, and ideas are included in the analysis and the designing of schemes and goals that will lead to create a post-COVID-19 world, which is more just and equal for all. Ignoring what youth have to say can lead to an incomplete understanding of their situation and the way we must seek progress, leaving on this especially important part of the population behind. To interrogate meaning and leadership of young people in health policy and decision making from ICPD, please welcome Mr. Levi Singh, who is the Youth SRHR Strategy Officer from the SRHR Africa Trust. Over to you. Thank you.
Thank you very much, Andy, and good morning to the fellow panelists. I am going to just pop on camera to say hi to everyone and then put my camera off due to bandwidth concerns.
Levi, your audio is a bit low.
Sure. Can you hear me now, Sandy?
Yes, I can. Thank you.
Great. Thank you. So thank you very much, Sandy, for setting that brief context and for ensuring that we have a segue from the Nairobi Summit commitments into this Generation Equality Forum process. And I think Sibu's ending had really catalyzed some of the thinking that has been emerging within the region pre-Nairobi Summit, and also looking ahead into the other processes in the region, such as the SADC SRHR strategy, as well as the updating and revision of the ESA commitment on comprehensive sexuality education and adolescent and youth-friendly services. I will try to keep my remarks to 5 to 7 minutes so that we can ensure adequate time for vibrant discussion with the fellow colleagues in audience. But really briefly, I think 2019 and the Nairobi Summit was quite catalytic to allow youth-led and youth-serving organizations and youth activists and advocates space and time to have very frank, open and honest discussions amongst themselves in terms of how we wish to be engaged in decision-making spaces. And I think the boiling point with regards to the Nairobi Summit was that as much as tremendous investments have been made in terms of resource and youth-led and youth-serving organizations, there is still a general sense of tokenism, exploitation, and manipulation of youth-led, youth-serving organizations, as well as activists and advocates in general. We have then, as a youth collective, under the auspices of this SRHR strategy, which was adopted in 2019. And I see many colleagues in the audience that were really part of that process. We came together to look at what are young people saying in terms of how they wish to be engaged when it comes to policy decision-making and programming that services adolescent and youth SRH broadly. And the key clarion call that had emerged from young people in their diversity was that we want to move beyond the slogans. And we've often now seen slogans being co-opted by our elder peers in terms of replicating the language of nothing about us without us, and calling for a seat at the table, and realizing how redundant now some of these slogans have become, because they actually aren't finding expression in strategies, methodologies, and mechanisms to promote and resource meaningful youth engagement, participation, and leadership. And out of the 14 consultations that we had held, the overarching call from youth-led and youth-serving organizations was to ensure that we have some sort of standard and guideline in place to ensure that we can institutionalize the meaningful engagement, participation, and leadership of young people in health and policy decision-making. And it was interesting that the strategies and guidelines focus specifically on how we shift power, how we increase the influence and move resources to youth-led and youth-serving organizations as a means to attain the ambitious goals we've set out for ourselves, either within the SADC SRHR strategy, the NDP 2030 in the South African context, and the Sustainable Development Goals at the highest level. And it was even more interesting that we did unearth the fact that in most countries, if not all countries in the Southern African region, there are mechanisms in place, be it through children's acts or national youth strategies, and these have all come from the African Youth Charter, but there are very significant resource gaps in order to operationalize many of these mechanisms. And sometimes these mechanisms are pretty much tokenistic in their approach of how they're engaging youth and just serving as a tick box rather than ensuring that young people are engaged meaningfully from the design of processes into the implementation, into the monitoring and evaluation, reporting, and into the entire embedded cycle of the policy development process. So I think what we're looking to do now in terms of this collective of young people is to organize in building a bridge between the Nairobi summits and what's been committed regionally and from a country level into the Generation Equality Forum process. And I think when it comes to the bodily autonomy and SRHR Action Coalition, the clarion call there has been to ensure that adolescents and young people in their diversity are able to exercise autonomy in decision making, not just with regards to their bodies, but even in political processes that determine their health outcomes in the grander scheme of things. And I think partners such as UNFPA and UN agencies, and even to a large extent the South African government, have been very supportive in terms of creating that conducive environment, but there's still many gaps. I see the next speaker is Marfeni from the Department of Health, and I think she'll reflect on the state of our adolescent and youth health policy and how there's an aspiration that is very vivid and specific in terms of what the state needs to do with other partners in order to institutionalize youth participation in health making spaces. And it's great to know that we do have these sort of mechanisms in place, but in terms of activating them and ensuring that we move from policy on paper to policy in practice, I think this is where we need to unite as a community, utilizing the momentum that's been generated by the Generation Equality Forum to really envision a future that ensures that we build back better and younger with the young people at the center. I'm going to round up by basically outlining where we find ourselves. So I spoke a little bit about 2030, and Mar Beatrice spoke about how the situation has worsened for adolescents and young people and their health and well-being outcomes, especially due to the socioeconomic fallout of the pandemic on our economies and our health systems more broadly. But I think it's alarming that in the last 12 months, we've seen around 300 million adolescents and young people pushed into extreme poverty, according to the IMF. And these are African adolescents and young people who were already vulnerable prior to the pandemic. And I think that the IMF is also warning us that the 10 years of developmental gains that we've seen in population and development issues in terms of the region are also at risk of being undone. And I think this then should force us to consider the commitments that we have made as member states, but also as young people towards the Nairobi summit process, and to look at the positionality and the seriousness and the intention of the Nairobi summit commitment process and how these might be expressed within the Generation Equality Forum. And I think lastly, it's about saying that there can be no building back better without the intentional investments in meaningful youth engagement, participation, and leadership at all levels. And we have 113 months between now and 30 in order to ensure that we get this agenda right, because fundamentally, if we don't get this agenda right, we risk ourselves further teetering down the path of demographic uncertainty, and we steer further away from the dynamic potential of our demographic dividend opportunities. And I really think that it's really time to get serious about what meaningful youth engagement, participation, and leadership looks like, because fundamentally, in the absence of standards and guidelines to inform policy and decision-making processes, anything that is done with young people can be reported as meaningful, and it could very likely act against young people and their interests, because it is not informed by them and their unique interest and their own priorities. The last thing I want to say is that the South African Action Coalition on Bodily Autonomy and SRHR is the only youth-led action coalition that I am aware of out of all the other action coalitions, and we're really urging all youth-led and serving organizations working in the space of HIV, SRHR, and gender equality to come on board and join the Action Coalition, so that we aren't just treating the Generation Equality Forum as a moment, but rather treating it as a moment to build a movement to ensure that there is greater awareness and that there's also greater directed towards increasing the visibility and vocality of young people in their diversity when it comes to the health and decision-making spaces. I'll stop there and we can take this further into the discussion segment. Thank you, Zandi.
Thank you, Levi, for those points of emphasis on intentional youth engagement. That is part and parcel of what we are trying to do with these dialogues, to make sure that we move away from the tokenism that you just mentioned, and make sure that in our design of strategies and approaches, young people are part of it, and also accountability frameworks, because at the end of the day, we agree that young leaders, but their problems are now, they should lead on the solutions to these problems now. And also just to echo on the call that you made to invite young people and youth-led organizations to join our work in the Generation Equality Forum, to make sure that their voices are heard, to make sure that for the next 5 years, 2021 to 2026, which is the lifespan of Generation Equality Forum, they are part and parcel of the implementation of the acceleration project. So thank you very, very much for that. So we've heard from many of our speakers on the existing measures, the policies, the programs that different entities from UN to South African government, as well as civil society organizations are working on. How do we prepare our young people for the transition from childhood to adulthood, with skills and motivation required to face the many challenges that they deal with, to lead healthy lives, learn how to identify and manage risk, and to develop and strengthen resilience. The National Department of Health adopted the National Adolescent and Youth Health Policy in 2017. To speak on this, in particular the Youth Zone model, aimed at increasing access to adolescent and youth-friendly services in the face of COVID-19, I would like to invite Ms. Fanny Imotwani from the Department of Health. Ms. Fanny?
Yes, good morning to my fellow panelists and participants, and thank you very much, Zandi, for the opportunity given to the Department of Health to share how the National Adolescent and Youth Health Policy through the Youth Zone is trying to scale up access of adolescent and youth-friendly services. Just as a reminder, the National Adolescent and Youth Health Policy was launched in 2017, and it has 6 principal objectives. If we can just quickly go through them, is the use of innovative youth-oriented programs and technologies to promote the mental health and well-being of young people, providing comprehensive integrated sexual and reproductive health services, test and treat for HIV, AIDS, and TB, reducing substance abuse and violence, promoting healthy nutrition and reducing obesity, and empowering adolescents and youth to engage with policy and programming on youth health. So now, what are these youth health? So one of the objectives talks to having dedicated clinic times for young people. And this is the name that is given to those clinic times that are identified by all the stakeholders, starting with the adolescent and youth themselves, the members of the community, the clinic committee, as well as the clinic staff. So they can vary between the health facilities. In other areas, you find them between 2 and 4 in the afternoon. In other areas, these are times that are offered over a weekend, either a Saturday or Sunday, or in other areas, even better, these are services and times that are available on a daily basis to also award the young people a chance to form youth support groups, as well as the time to do their homeworks together. So what can young people now expect in this youth zones, or actually what are these adolescent and youth-friendly services facilities? These facilities are facilities that are run by skilled and competent staff that are trained primarily in adolescent and youth health. And the staff, these are patient and understand the age and understand the needs of the young people, which is age appropriate, because the young people here, we're talking of youth aged between 10 to 24 years of age, but when engaging with them, further categorization is done for 10 to 14-year-olds, 15 to 19, and 19 to 24 years. And of course, bearing in mind and in alignment with the comprehensive sexuality education offered for in and out of youth schools. And furthermore, this adolescent and youth-friendly space services offer a private space to talk for young people and also to be examined. Furthermore, young people are also helped and guided to access appropriate and services that they need in the language that they understand, you know, the local language that is spoken. And also what is guaranteed is that everything that is discussed during these times is kept confidentiality, unless of course, if further management has to be offered, and this can be communicated within the multidisciplinary health officials. So we've got a comprehensive package of services that is offered to young people. This starts with screening for malnutrition, obesity, substance abuse, violence and sexual assault, and mental health issues, because we know that our the social ills that are prevalent in our communities, and further then providing the necessary psychosocial support, because this is not services that only are offered by professional nurses, but they are engaging all or encompassing all the multidisciplinary stakeholders, your social workers, the schools themselves, the community at large. So the appropriate referral is also made available. And then in these times, the immunization for TD is also offered for your 12-year-olds, screening for post-exposure, screening for any violence and sexual assault, and even offering post-exposure prophylaxis, treating of any minor ailments, maybe if sustained during school time. The educators and the community, they are aware that they can take the young people to the facilities, and they will be going or redirected to these areas that offers services for young people. And the most important thing is also health education and information on prevention of unwanted and unintended pregnancies, and in case and also abstinence from or delay in sexual debut. And then if they are ready now, your 20 to 24-year-olds to indulge in sexual activities, to also offer pregnancy support and pregnancy testing. Once pregnant, then you encourage early bookings for antenatal care services. Or if this is one of those unintended and unplanned pregnancies, the appropriate services are also offered and advised, with other alternatives such as adoption or even choice on termination of pregnancies. And then, of course, we still emphasizing on HIV counseling and testing, and the administration or prescription of scaling up of antiretroviral treatment, HIV prevention packages, and prophylaxis or pre-exposure prophylaxis, and of course, the formation of the support groups and treatment adherence and support groups. And then with other, the most and primarily package is your sexual and reproductive health services, because we know it's only now through the integrated school health services that these were allowed in schools, but they were also disturbed with by this COVID-19 pandemic, as the national rollout was supposed to be in 2020, but now we know with the school closures, this was unable to also take off the ground. But these are other services then that are taken or further provided in your health facilities. So how do we then identify this adolescent and youth health facilities? Through our Ideal Clinic manual assessment, we've got what we call the element 44 component of the adolescent and youth friendly services, and over and above assuring service delivery to the young package. But we also have a systemic approach in ensuring that these services are indeed available in those facilities. So through the Ideal Clinic, there will be the assessment, and there are 7 questions that are asked to test if the facility is offering these services. So we want to know that the staff are trained in the adolescent and youth health policy, and the policy is actually available on site. And is there a poster that is also indicating this dedicated clinic times, their consulting times, as well as the package of services? The facility staff development plan should also make provision for all healthcare professionals to be trained in AYFS, not only the 1 or 2 professionals that were available when the program is launched. And the training A register should also be submitted to the next level of care. So from the facility, it will go to the sub-district, the district, the province, and then to the national office. But also what is important and aligned to what Levi has just alluded to is that in the clinic committee, there should be a representative of an adolescent and a young member. So primarily, this is, they should be appointed from the age of 18 years so that they can represent and talk to issues that are affecting young people within that catchment area. And also the facility itself should have a brief profile that outlines challenges that young people in that catchment area experience, as well as the recommendation how to manage these facilities. So once those are in place.
Sorry, Ms. Mutwani, can you please wrap up, because we also want to allow time for the interactive dialogue. Thank you.
Okay. Once all those are in place, then they can invite the National Department of Health to then launch the facility as adolescent and youth health friendly. And then they will also be provided with the posters and banners that show all these youth zones and services that are provided. Thank you very much for the opportunity and listening.
Thank you very much for that very detailed presentation. And I would like to take this opportunity to thank all the panelists for all their interventions. And now it is time for us to actually interact with our audience who have been paying attention. I'm sure they cannot wait to ask questions or make their own comments on the presentations that were made, or just on the theme that has been chosen for today. With that said, I am now gonna open the floor for any interventions. If you want to speak, please raise your hand and I will identify you just for order. Colleagues, the floor is open for any intervention. Well, from my side, I am not seeing any request for the floor. In that case, I would just like to give my panelists the opportunity to okay, I'm being made aware that there are questions and comments on the chat. Colleagues, if chat, please, you may take the floor and ask your questions, because I am also trying to follow the chat while moderating the session. All right, colleagues, with that said, I will now just allow our panelists to make any additional maybe observations from the presentations made by fellow panelists, and we will take it from there while we wait for the questions. Or I see one of the questions is, how can youth be active in the acceleration program? That is coming from Tamira Kasi. So any takers from my panelist?
Hi, Zandi, I'll jump in.
Thank you, please go ahead.
So thank you so much, Tamara, for the interest. So there is the Generation Equality Forum working group on bodily autonomy and SRHR. And there is also another working group that focuses on young people specifically from a variety of movements, be it the feminist movement, be it the climate movement, or even young people working in the SRHR, HIV and gender equality space. And I'll be more than happy to link you with colleagues and to ensure that your organization and fellow young people are adequately represented. So please pop your email address in the chat box and we will do the necessary follow-ups.
Thank you, Levi, for that response. If there are no further comments from the panelists, I would like to invite Ms. N. Kitukushong. Oh, sorry, I see that Jacques has a hand up. Please go ahead.
No, it's okay, Zandi. If you wanted to introduce somebody else first, it's fine. But I also wanted to throw something into the discussion.
No, please go ahead, because the speaker I was about to call upon, she will be doing our closing remarks. So yes, everyone must speak before her.
Okay, yeah. I think we got the sense that we were making progress in some areas, let's say until slightly more than a year ago, and some of the trends that have been shown, for example, in the SANAC presentation, suggested that some of the outcomes are changing, which means that some of the advocacy and services might be working or starting to work. And then, of course, we had the impact of COVID, and I think many of us were very smart and moved a lot of the advocacy work that could not continue to social media. But I think towards the end of last year, we started realizing that with the shift of SRHR advocacy to young people to social media, we were actually not reaching many young people anymore, particularly those who probably need information and services most, the poorest, as well as young people who live in rural areas. So I just wanted to maybe, check with other panelists as well, and particularly maybe Feni and Levi, how do we ensure, that we don't leave those who are behind even further behind, whilst, modernizing in one way our work, but on the other hand, without such people having the socioeconomic means to actually continue to access information that is necessary. Thanks.
Thank you, Jacques. The Koketo.
Yes, thanks so much, Zandi. I just wanted to just respond to what Jacques is alluding to, just to also agree that, yes, we had seen very enormous challenges, especially with reaching young people who may not have access to social media platforms or just digital platforms broadly. So I think also I did highlight it quite briefly in the presentation that we also need to strengthen support for community-based organizations that work within communities, because one thing that we have to come to realize about SRH services, especially from an institutional perspective, is that it's very structured and there's a certain way and sort of pathway that you need to follow to access. However, community organizations are within communities, they live with the people, they're able to continually monitor what is happening in communities and see the needs and where to sort of chip in, and that could be a good mechanism to advise government and advise implementing partners on key areas of strengthening when it comes to sort of bringing services to people, so such as mobile clinics and such as things that we can optimize that do not really further isolate young people who may not have access to these digital platforms. So I think us moving into a digital space should not really make us to become less, interpersonal or less, sort of working as from a communal point of view. So I think it is important for us to try as much as possible to still integrate those in-person mechanisms that have worked for years, and of course adhering to protocols and regulations, but still ensuring that those systems are strengthened because they've proven to work. Thank you.
Thank you, Koketo. Is there any other person who would like to? I see Larry Cook. Please go ahead.
Hi everyone. Thanks, Andy, for the opportunity. I'm just listening to the conversation that's transpired, and I mean it's really rich for my own benefit, really. I just always question these type of conferences and the reach in terms of what was said on this call and where would this information be disseminated in smaller bite-size information that perhaps is podcast, that's perhaps maybe shared on local radios, that's perhaps shared on Facebook's platforms and other social media platforms, just so that I think the youth can get a feel of the fact that there is work that is being done, or they're still top of mind in certain conversations. Because I think there's also a low morale that exists in the community that I've picked up in my engagements, where the youth doesn't feel like they're part of this government, yet alone part of the economy, in the sense that they are just afterthought. And when it's necessary for votes, then it's something that you include. And also, if you want to boost your CSI initiatives, then you involve youth to tick off certain boxes. So I mean, what Levi was raising up, I 100% back that sentiment, is that even as an older youth, so to say, you've grown up through advocacy from your early 20s up until now. You're peaking on your 30s and you're bordering your 30s, and still nothing's changed. You've participated in all these awareness campaigns. You've participated in all these feedback sessions, but still you feel like nothing's being done on the ground level. And the question is really, are we being taken serious? Or does it have to take another Soweto uprising for our voices to be heard? And I mean, I say that quite desperately because, especially with the stats that were shared, I mean, it's shocking. I mean, it's absolutely shocking. In fact, it's disgusting. I mean, why are there not adverts that play at peak times between Bold and the Beautiful and Days of Our Lives on SABC, whatever the case is, illustrating and highlighting how it's a complete no-no for abusing women and gender-based violence? Why aren't those messages being shown? Why aren't there billboards left, right, and center that show the complete disgust that we share as a community around gender-based violence and things like that? Because I mean, the horror stories that come out on the newspaper and things that happen, I mean, it's an everyday thing. We're so desensitized to these stories that it's like acceptable to have them in news stories daily, which I guess that's where I'm coming from. And my ask and the solution going forward is that this is good. This is a good step, but I do think that the dissemination of these type of initiatives need to be more far-reaching. I think more budget needs to be allocated in terms of advertising. And I mean, media is one of the biggest platforms that is being consumed, especially being given our lockdown situation. So there is definitely more consumption that's happening on TV, on social media, etc.
The voice needs to be heard. You need to add value and come up with suggestions so that we are able to be part of the conversation and create the change and transformation that is needed. Thanks, Zandi.
Thank you, Masichaba, for those intervention. I will now invite Mr. Singh again.
Thank you very much, Zandi, and incredible contributions coming in from fellow panelists as well as the audience. And I really do echo most of Larry's concerns and endorse many of Koketso's interventions. I think just to respond to Jock in terms of the need to reach the most left behind and the most pushed behind, I think one of the most fantastic that, Larry, your intervention is so on point. And I do think that the Action Coalition, as well as broader youth-led, youth-serving organizations and youth formations in the diversity, really need to be holding the broader development community to account in terms of the investments that are being made into the youth development ecosystem. It's completely unacceptable that every leader will take a platform and talk about youth being the future and emphasize the importance of youth development. Yet data tells us that only 2% of global development expenditure has gone towards youth-led, youth-serving, and youth-focused organizations since the year 2012. And it's very easy to go to respective platforms and to talk about investing in young people when we aren't willing to invest in the capacity or even invest in the material resources that are needed to ensure that youth organizations can organize and mobilize and really deliver on the implementation of policy and programming and play that oversight role. And I really think that we need to use this opportunity. Lastly, I think maybe UNFPA could speak a bit more about the emerging opportunity as well, with the ISA commitment coming up for review and the national process, and maybe some plans to engage youth, to affirm the importance of comprehensive sexuality education and accessing information education for young people in their diversity. So I would maybe put the floor to back to you, Zandi, and maybe if someone from UNFPA could speak a bit more about how the UN plans to engage some young people in that process. Thanks.
Thank you, Levi, for your intervention. I don't know if from my panelists, anyone else would like to take the floor. Otherwise, I know we are over time. We're supposed to finish our session at 12 o'clock. According to my watch, it's already 8 minutes past 12. So if there is no other request for the floor, I would like to now invite Ms. Anne Githukushongwe, who is the head of UN, or the UN Women Rep in South Africa Multi-Country Office, to give our closing remarks. Sis Anne, over to you.
Thank you, Zandi, and thank you to a very, very rich conversation today. Really great dialogue. And Larry and Levi, we hear you loud and clear about how to make sure that this is something that is concretized and not just a conversation. So we're hoping that it would come through. You know, I did hear a question to UNFPA, and I didn't know whether or not UNFPA should say something, Zandi, before I go on, because there was a specific question about, and I don't know if Beatrice is still here, or Precious, or Zianda, or whether I should just go ahead.
Oh, yes, sis, and if UNFPA would like to respond to the question that was posed by Levi, I think they can speak before you wrap up. UNFPA. Well, from my side, I'm not seeing any requests.
Okay.
And I think...
Hi, Cindy.
Yes. Please go ahead.
Precious Mahokhori, may I?
Yes, please come.
Okay, can you hear me now? Okay, thank you so much for that question, and thank you so much for an engaging webinar. This has been quite enlightening and more insights gained in terms of youth participation and what needs to be done. For the specific question that was asked around the ISA commitment, we recently partnered with UNESCO and with UNAIDS, and we partnered with SANEC on engaging young people. And I think we gained quite a lot of insight from there and a way forward in terms of how better to structure the engagement going forward in terms of the extended period for ISA commitments. And we definitely will be working in partnership and collaboration again with SANEC Youth Sector on how best to engage and going forward, because the main recommendation again that was emphasized in the platform was that, again, the issue of meaningful participation, and that it needs to start at district and provincial level for that engagement to commence. And more importantly, how we engage is also around induction on the ISA commitment itself, and how this links with other strategies around SRHR, with strategies and interventions in the country. And definitely that is where we are moving towards, with a coordinated collaborative process with SANAC. Then we will be able to engage going forward. Thank you.
Thank you for that, Precious. And I think, Sis Anne, you can now go ahead.
All right, thank you so much. Thank you. I suppose, I've been trying to think, this conversation is so rich. It's not one of these that you want to actually try to pull together. And I think you've been doing a great job, Zandi. But just to say that the generation equality in our lifetime, because if we continue at the current pace, and Larry and Levi and others made very clear the frustration in, on the one hand, we are engaged and we're recognized, but on the other hand, the true investment in the issue of SRHR and all the ancillary issues around have our own specific issues, and we want the world to listen to us. And so they actually prepared a sort of list of demand that they call Dear World, You Must Listen. And there were over 160 participants there who talked about what are the issues as young girls that they want to champion, and what are the girl-specific issues. And so they kept talking about the girl-specific issues that they want to be on the table, that they will champion, and that they want others to champion with them. And so, trying to make that as a distinction. So before I go to the overall sort of actions, I thought I would raise some of the issues that they've talked about. So they actually did a very interesting analysis of where girls' sexual and reproductive health and rights are impacted across all the action coalitions of generation equality. So what is the impact of and what are their demands in relation to climate justice and in relation to the economy, and really looking at how do we make sure that even in the context of the circular economy, as you're looking at the environmental concerns, how do we make sure that sexual and reproductive health and rights are prioritized and are aligned with gender justice in terms of access, in terms of availability and accessibility of the circular economy for young women and girls. Now, this was raised by a young woman from Chile, and so these are from across the world. In terms of economic justice, Laura, who's from Venezuela, also raised where she's basically saying, if we're going to be serious about girls' sexual and reproductive health and rights, we need to be looking at their empowerment, girls' empowerment, investment in terms of their education, in terms of the economy, and as well as self-love. So let's clarify what we mean when we talk about empowerment, because sometimes empowerment is sort of thrown into a basket which assumes, a workshop here and there does the trick. But we're basically saying here that it's about educational empowerment and access by all girls, all young women and girls, looking at the economy and the engagement in there, and then about self-love in particular, and how do we actually invest in that. And then also the ensuring gender equality in schools curriculum and household education, which is an interesting one. And for household education, well, that's not so clear how that happens. I think that the vehicles have been churches and, sort of faith organizations and some of these other ones. But the concept of household education, for me, I think is quite interesting, and one that we need to have some conversations about. I know that there's some parenting work that our colleagues at UNICEF do and UNFPA as well, but we just need to think a lot about how do we actually start penetrating the household, so that some of these, the challenges that all of you are raising are actually penetrating our society that way. Natasha from Zimbabwe shares, from a gender-based violence perspective, there still isn't sufficient provision of services for girls when it comes to GBV-related services. So we may have our own debates around reproductive health and rights services, but even in relation to gender-based violence, girls themselves are unable to sort of show up in spaces. There are no shelters that are available, and so there's a request that there needs to be an investment in girl-specific facilities for gender-based violence, and a call to start naming the issue of child marriage, or naming is norming. So change this language. Stop calling it child marriage. This is not child marriage. This is about rape and violation of children's rights, of young girls' rights. And this is quite a big issue in our region. In South Africa, we've seen this playing out quite a bit, where young girls were being married off during COVID in exchange for food and cash. But it continues in different communities across the country, but also very much across this region. And yet it's still, the nomenclature of child marriage still used, it almost sanitizes it. And so there's a real demand from the young girls to say, shift that language and let's talk about it as real rape and violation, and really push for the re-entry into schools for those who have been victims of child marriage, so that there are no barriers to entry, as there are in some countries where, a girl who has been pregnant or a girl who has been known to be engaged in sexual at school. So really how to ensure that this is not perpetuated. And then the demand that the silent epidemic of schools and campus sexual violence has to be recognized as a silent epidemic, and one that requires measures that are much more placed on the perpetrators, that they're held accountable, that there are appropriate measures to transform perpetrators. So really concrete things that were emerging. Another one is a request from this same young girl to increase funds that are dedicated to deal with human trafficking and sexual exploitation, which is rampant now in many of our countries, and ones where the impact of pregnancy, HIV, other STIs really are pronounced even in these cases of young women and girls. So, these are the sort of, demands that are emerging from young girls, many of these between the ages of 14 to 17, who are saying that if generation equality is going to make a difference, there has to be a way in which these social norms, and there's a lot of proposals here about shifting the norms and culture and really being able to get to the bottom of where abuse of young women and girls, culture of sexism, the intolerance of LGBTI, this whole norms that are accepted in our communities and our societies through our churches and so on, be confronted, and the creation of a fund to support organizations, women's feminist organizations, girls' feminist organizations that are really pushing to change the game for young girls. So very interesting emerging conversations coming in from these girls. And I just thought that I would share that with you just to see how we include it in this conversation on SRHR for the country. And then just to go back to the Action Coalition work that is underway, I mean, this is work that is going to be revealed in its fullness during the Paris conference, and really would be the moment to accelerate these actions over the next 5 years, so that we do indeed start seeing a change in what looks like is 200 years away from us, unless dramatic change happens. And so I'll just share the vision. I mean, I'm not going to talk about all the different things that are emerging from that, but I thought that the vision is just interesting to listen to. So the first part of the vision is that all people, particularly girls, adolescent women, transgender and gender non-binary people in all their diversity, are empowered to exercise their sexual and reproductive health and rights and make autonomous decisions about their bodies, free from coercion, free from violence, free from discrimination. So that's the first one. The second one in this vision is that SRHR information, education and services are freely available, accessible, acceptable, and of high quality. Girls, women, and feminist organizations and funds, including among others, girl and youth-led, disability-led, indigenous, LGBTQ+ human rights defenders and their allies are strengthened to advance SRHR, and more governments promote, protect, and invest in SRHR, including as part of universal health coverage. And the third one is working across all the action coalitions with multiple stakeholders and at all levels. We transform gender and social norms. We promote gender equality. We apply intersectional, intercultural, human rights-based approaches and improve SRHR outcomes, leaving no one behind. But the big issue is the how and what are some of the actions. So in the actions, the increase of delivery of comprehensive sexuality education in and out of school, reaching 50 million more children, adolescents and youth by 2026. The action 2 is within a comprehensive framework that includes SRHR services as an essential component of universal health coverage, is contraceptive services for 50 million more adolescent girls and women in all their diversity, and the removal of restrictive policies ensuring 50 million more adolescent girls and women live in jurisdictions where they can access safe and legal reproductive health and abortion by 2026. The norms change and increasing knowledge of rights empower all people, including 260 million more girls, adolescents and women in all their diversity, to make autonomous decisions about their body and reproduction by 2020. The fourth one is to increase of and support for autonomous feminist and women's